Hi, today we will talk about central line placement and the IJ ultrasound guided in our skills lab in University of Missouri, Kansas City, UMKC. And we'll start with this checklist. So this checklist is very important to follow so we don't skip any of the steps. Be sure we have everything done. So if I start with the first thing is the consent. Consent needs to be taken from the patient or family if the patient cannot give a consent. Unless the procedure is emergent procedure and you need to do it, patient cannot give a consent, family are not available. In this condition, you have to do the procedure, document that you couldn't get a consent as the procedure was emergent procedure, and we will go for there. In the consent, I don't recommend that new learners who never did the procedure or did very few of those to get the consent. Patient would like to know what are the alternatives of the procedure, and this is part of your consent. What are the indications to put the central line? What are the possible complications that may happen? How rare they are? And you need to tell them what will you do if you develop any of the complications. We will have a separate video for the didactic about central line indication, contraindication, consent, sterility, complications, and how to manage the complications. So this will be a separate video from this video. When you get the consent, be nice to the patient when you are getting the consent, confident in yourself, and don't scare the patient about the complications when you are telling them about the complications. So after you get the consent or document that the consent was not done because of the emergency of the procedure and no availability for anybody to give the consent, you need to do timeout. Usually for the timeout, nurse in the hospital should be with you in the room and she can document the timeout. If the patient can give the timeout, usually timeout is patient name and patient birthday. So if the patient is intubated, sedated, one of the people present in the room can tell the patient name and his date of birth, and then also you need to in the timeout determine what procedure you are doing, central line, thoracentesis, paracentesis. And when you determine the procedure, you need also, if you have a procedure like thoracentesis can be right or left, or any surgery or something that can be either right or left, you need to determine the site. The last thing in the consent, you need to talk about patient allergy. Be sure that none of the medication used during the procedure the patient has allergy to. So after you get the timeout, you start to get your procedure. So position is very important. So when you do central line, you need to put the patient like our mannequin here in Trendelenburg position. Trendelenburg position will give you two benefits. One, your vein is usually collapsile in a patient when you will need the central line for patient who is hypotensive or patient who is significantly dehydrated also. Then in this condition, you need to put the patient in Trendelenburg. So this will get you two benefits. Vein will be more engorged, so you can access the vein easier. The second thing, you will have less chance to get air embolism because the vein is now full of blood and the pressure inside the vein is higher, so less air can enter, especially if you use the technique when you separate the syringe from the needle to start wiring through the needle itself. So this is the importance of the position. Then sterility, it's important for every procedure to have full sterility technique. You need to wash your hands. Why should I wash my hand if I'm wearing sterile gloves? Washing hands is very important in case your glove break at any point. Your field is as sterile as you can until you get some other glove and wear it. So any person in the room should stop the procedure if there is any break of the sterility. So if your hand touch anything that's not sterile, the nurse in the room or your assistant or even the student in the room can tell you, please stop, your hand is not sterile now, you need to change your gloves. So this is important. Don't be upset of that because this is for patient protection, and we are all working on our patient protection. Line, it is important to get the patient in a Trendelenburg position. Trendelenburg position with the head little bit down, like what we have here for our mannequin. So Trendelenburg will get you two benefits. One, our patients are usually hypotensive or hypovolemic, so your veins will be collapsing and they may even collapse with your needle trying to go through the vein. So it's important to put them on the Trendelenburg so your vein will be more engorged, so it will be easier to access. The second benefit, this will reduce your chance to get air embolism. So air embolism is one of the complications of this procedure, and if you have your patient in the Trendelenburg position during placement of the line and even during removal of the line, this will reduce your chance to get air embolism. So position in the Trendelenburg position will get your patient the best chance to have more engorged veins so you can access, reduce the risk of air embolism. Next will be, I would like you to get some idea about the ultrasound that you are using. So here we will use the vascular probe. This is our ultrasound machine. Our vascular probe, this flattened probe. And here we have a small knob. This is where your green mark there on the ultrasound is seen. So if you look at the green mark, this is where your small knob here. So if you are not very familiar with the ultrasound, I would like you to put your probe in front of the screen, and then get some gel on the tip. You see how the picture changed? And you tap on the side. You see I'm tapping on this side, and it's matching the side where the dot is. So now this will be, if I want to move on the screen this way, I can move my probe this way. If I want to move this way, I can move my probe this way. So tapping this way. If I have my probe the opposite, so if I tap here, I'm tapping on the left side, and on the right side of the screen, I see the tap. You have to tap the crystal. So you need to correct the position so you have that. Okay. Before we start getting sterile, I would like you to assess 4 things in the patient to see how you can insert your line safely. Number 1, we will hold the probe like a pencil with not much pressure. You start to look at your screen there, and in your screen you need to see a couple of things. One is the artery, more medial, and the other one is the vein. Vein and artery, here in this mannequin, they are aside and a little bit far from each other. They may not be the same in reality. Let me show you some pictures how they would look like in reality. This is a picture here where we have the vein, this is the lateral side, and the artery are beside each other. And this is easy because when you go with your needle to the vein, you will not get close to the artery. Not everybody has that same thing. This is another one which is more close to reality, which is the vein is more anterior and lateral to the artery, and they are touching each other. That's why sometimes we see the vein is pulsating because it's conducting from the artery beside it. So this is more reality. Vein looks like a little bit more triangular, not circular. The artery is beside it, artery is medial, and vein is lateral and anterior. This is the most difficult one. If you see your vein and the artery is beyond it. So this is the most one that you need to be very careful, because when you go with your needle, sometimes you pass the vein, and in this condition you will access the artery, and instead of placing the central line in the vein, you will place it in the carotid artery. So this is the most difficult anatomy that you need to be very cautious, and maybe don't teach or learn in this anatomy. So because this may be difficult to control your depth if you are a new learner. So this is the common, this is the easy beside each other, and this is the most difficult when the artery is just behind the vein. Okay, when we look here back again to our ultrasound, so I will move until I find my vein and my artery, and then I will concentrate on the vein. Vein is less compressible than the artery, is more compressible than the artery, but also if you see there is a line that's white inside the vein, this can be a valve, and veins have valves, arteries don't. So this is another thing to reassure you that this is a vein. And you can follow the vein with the anatomy until you find the best position and you concentrate on the vein. Once I concentrate on the vein, this ultrasound has these green dots. I put the vein in the middle of the vein at these green dots, and this will be a good position for the vein. When I use the ultrasound, I like to be easy. I will stand myself and the vein and the ipsilateral nipple and the ultrasound machine in one line, so I will not switch my position too much. It will be easier for me to access, especially early. Once I get the vein in the middle of the screen, I will freeze. When I freeze, I'll leave my probe. This is all before I started to get sterile. So you determined your vein and artery. Look at the vein, and your vein is black. Black means it does not have a thrombus. If you see inside the vein gray like this surrounding, then this vein has a thrombus. So be careful. You don't have to touch this vein, because if you put needle through the thrombus inside the vein, you will get pulmonary embolism. So first thing, get the position and look at your vein, completely black. This means your vein is patent, so no thrombus inside. If it's gray like the surrounding, don't touch it, this vein is thrombosed. Second thing, you need to measure the depth, how deep is your vein, and you will get a caliper and you will move to the surface. This is where your probe is, skin. Then you will select. Then I will move the other one to the middle of the vein. This is how deep my vein is, and here it is 1.4 centimeters. So my vein is less than ½ inch deep. So we shouldn't go very deep with our needle, because your vein is very superficial. Then I will get another caliper and measure the vein diameter. I will put my spot there, I will select, then I'll put my spot on the other side. So my vein is 1.1 centimeter. This means my vein is 11 millimeter. It can accommodate a catheter up to 11 French. Why is that? 1 millimeter is 3 French. And if your catheter occupies more than a third of the vein diameter, it will slow the venous circulation and will increase the risk for thrombosis. So if your vein, say the triple lumen, most of our triple lumens we use 7 French. If your 7 French can go in a vein that's size up to 7 millimeter, not less than 7 millimeter. Your 7 French will occupy more than a third of the vein that has a diameter less than 7 millimeter. So your vein diameter in millimeters should be at least equal to the catheter size in French, because 1 millimeter is 3 French. So this vein can accommodate up to 11 millimeter catheter. If your catheter is 14 millimeter, don't place it in this vein 11 millimeter, because you will increase your chance to get thrombosis in the vein in the future. So we checked. Our vein is patent, no thrombus. We checked the depth of the vein, and here it is 1.4 centimeter, nearly ½ an inch. We checked the diameter of the vein to see if the vein can accommodate the catheter that we are placing. The last thing, I would like to go to the mannequin and measure how deep I will need to go with my catheter. We determined that this is the spot that we will go with the ultrasound. So this is my spot where I will go with my triple lumen. Then I measure from this spot to the junction between the SVC and the right atrium. This is where you want your central line to be. How can we measure that? Your vein and the right atrium junction is in the third right intercostal space. So this is how deep you need to measure. So everybody can put his finger on his suprasternal notch, then go down. You will feel the bony ridge, which is the junction between the manubrium and the body of the sternum. This is what we call sternal angle or Lewy angle or Lewis angle, whatever the name you want to call it. The rib attached to that is the second rib. Usually space is below the rib. So second space will be below the second rib, third space. So I measure from the insertion site that I selected with the ultrasound to the third intercostal space and go this distance. This is how deep I would place my central line. If this distance is 12 centimeters, maybe better to get a catheter that's 15 centimeters. So you don't have too much redundant extra length outside. If this is 16 centimeters, then you get the 20 centimeter triple lumen. If you are placing from the left side, you measure the same thing from the site of insertion that you picked with the ultrasound, and you go down until you reach the right third intercostal space, because you have only one SVC. So this will be a little bit longer distance. In most average size people, you will need the 20 centimeter catheter. Very short people, you can go with the left IJ with 15 centimeters. But you have to measure the distance. This is how deep you need to go with your line after you place the triple lumen. So this is the last thing you need to check. So we checked vein is patent, not thrombosed. Check the depth of the vein. Check the diameter of the vein. Check the distance from the insertion site to the right third intercostal space where the SVC right atrial junction is. So we did all these things with the ultrasound. we knew our ultrasound machine. Let me show you our central line kit. And our kit has the ChloraPrep. So when you are getting sterile, you need to sterilize your patient. So when you use the ChloraPrep, when you sterilize, what I want you to sterilize, not just the site of insertion. What you need to do, you need to sterilize from nipple to midline to the whole neck to the lower jaw. So all this area should be cleaned with ChloraPrep, because the hole in your drape may move a little bit, so you will need to be sure you are getting into sterile field. Sometimes you try to place central line, you cannot get it for some reason. You can move your hole to the subclavian, you can place subclavian, or the opposite, so you don't have to get off sterility and get things started from the beginning. So when you clean with the ChloraPrep, nipple to midline to the whole side you are working on, whole neck, lower jaw, this is how large you need to clean. ChloraPrep, if it's not dry, is not sterile, so you have to leave it for at least 3 minutes to get dry, so you are sure that your area is now sterile. So this is how you clean. While your ChloraPrep is getting dry, you can work on your kit. What do you need to do for sterility? You need to wash hands. So washing hands. Why should I wash hands when I'm wearing gloves? Because your glove may break at any time, then your field will stay as sterile as you can. So any procedure, you need to wash hands before you start. Then you need to wear a hat or head cover and a mask, the head cover and the mask. I prefer that you wear a mask with a plastic shield, because if blood goes to your eyes, you may get infection through the eye. So HIV can be transmitted through, especially an arterial line or any central line or something. If the blood comes to your eyes, then will be harmful for you. So wear a face cover with a plastic shield, the hat. And actually everybody who is in the room should wear the head cover and the face shield, even if they are not getting very close to the patient. So if you have anybody who's assisting you, he should wear all the sterility things that we'll talk about. So we cover the head, we will wear the mask with the plastic shield, then you will wear your sterile gown and you will wear your sterile gloves. So now you are ready to do the procedure. Drape that cover the whole body. This is your thing, you will need to remove that plastic part. Look here, this is where the head is. So this should go this way. What I will do, I will remove this plastic part and I will have this sticky thing there. So after you clean with the ChloraPrep and you left it to dry, you put your sticky thing around the area that you are planning to do. Once you get that, you will spread your kit as much as you can to cover the whole patient. Okay? Then this side. Then you spread it and you cover the whole patient, even the feet. So this should spread till the feet. Okay, now this is my area that I will have to do. This is my sterile field, and now I can start getting my things ready there. I will try to stick that sticky part on the mannequin so we don't have any part that's not sterile. Now this is a sterile field. I'll get to my kit. Okay, we'll start with, this is my syringe and needle. We'll take that out. You see this needle is about 6 or 7 centimeters. We measured our vein is only 1.5 or less centimeters. So really if your kit has only this long needle, if you go half of your needle and you don't get blood, you are not in the proper direction or you pass your vein. So this is the first thing. Always when you are going in, you should hold the syringe in a way that you can suction. This way I can suction. You can hold it anyway. You need to get trained how to suction with the syringe. It's not an easy thing. If you try to practice, it's not an easy thing. So this is the long needle. Our kit here, and same thing in the hospital, we will have a shorter needle And this shorter needle is good for IJ, because we said IJ is only 1.5 centimeters. So this needle is enough to get for the IJ. Will not be enough if you want to get femoral or you get subclavian vein. So this needle will be good to handle a patient for IJ. Okay. So this is the first thing, the needle. Here our needle has a hole in the back where I can place my wire, and this will allow me not to separate the syringe from the needle, because this is one of the steps that if you do that, that's okay, but this may increase your chance to get air embolism, because now you are open to the air. When you have your syringe connected to the needle and you wire through the back of the syringe, then you don't have anything open to the air at all. So this will be one of the things that I wanted to let you know. This is my syringe, and I will put it on the patient just here on the drape to get things ready. This is another thing, is the wire. The wire comes covered this way, and this is how you prepare the wire. You take this cover and you need to pull back this wire inside the nozzle. Now this wire is prepared. Once you prepare it, you can put it on the patient drape. This is a dilator that I will need to use. Also, this is another thing that I will need to use, and I'll put it here also in front of me. If you have somebody who's helping you, you may be able, or you can leave it there, but I like him to be ready in front of me. This is my triple lumen, and this triple lumen, you see, has 3 lumens, and this is 20 centimeters. So here is 15, and goes 16, 17, 18, 19, 20, and this is the cut for 10. So here is 10. If you look closely, you have a distal hole where the wire will go through. You have 2 proximal holes, one here and one here. You see this distance is longer than the 1.5 centimeters. So you may still have one hole outside the patient's skin and the other hole inside the vein. And this is important when I'm taking this out, because if you take it slowly and the patient is sitting, then he has a hole inside his vein, a hole outside the skin. If he takes a breath, then air will go and you get air embolism for this patient when you are removing the catheter. So we'll talk at the end how to remove it. Patient should be flat, Trendelenburg if possible, and you cut the sutures or release your stat lock, and then once the patient is ready to take it out, you ask him to hum. Humming means he's exhaling. Once he starts humming, you pull it quickly, so you don't have a chance for him taking a breath with one hole outside the skin, one hole inside the body. This triple lumen, you need to flush it first, and this kit comes with its saline flush. So you have 3 amps of that. They come in this blue coverage. So this is different from our lidocaine. Our lidocaine is a different bottle here. So, okay, so you will get that opened, and then you will fill your syringe with that fluid. This is sterile saline. They come also with some suction things. You can remove the syringe if you want, and you connect that, and you can suction through your through your saline and get your saline inside. Once you get your saline inside, you start to flush it inside the triple lumen. Flushing through the triple lumen is important because of one, you need to be sure all your ports are patent. So the brown one is where your wire will come out, and this is the shortest. If we look here, this is the shortest lumen, because shortest will be the most distal. The next one in length will be the hole in the middle, and the longest one will be the most proximal hole. Once I get my saline, I will flush my lumens and will remove those caps. And this kit is nice. It comes with the certain caps that you will use. So you will get your saline, you will flush all the lumens, be sure they are patent, and then flush the second one. All of them are patent. Then you need to place the caps that they come that you will use later on. So these are the caps that nurses like to, these are power caps. You can inject through that and has a valve. So you connect the cap here, the second cap to the other one. I will leave the one where my lumen, my wire will come out open. So I will not cap it. So this will stay capped. Now this is flushed. I will put it now with me here. If you are planning to do incision, you can do that. This is your scalpel. I usually don't do incision, but if you are planning to do incision, you need to get your scalpel with you there. We will not do incision on the mannequin, and most of the time I don't do incision on the patient. But this is a possibility that you can do your incision. Great. Okay, now let's go back to our patient and see what we will do and how we can proceed with the steps. Patient can be on ventilator or can be awake. Even if they are awake, I would like to get some local numbness in the area. So you have your lidocaine bottle, use your small syringe with a small needle, get some lidocaine and numb the scalp. So when we get the lidocaine, just at the point where we are doing the procedure, you just inject a little bit of lidocaine below the scalp. Okay, now we need to go back and use the ultrasound. Here in this thing, you have two things. One with the sponge, you can put your needle in it, and you can get the needle again if you want to use it. The one with the fan-like, if you put your needle, it will clip on it, you cannot get it back again. So this is the trick. Now I numb the skin. Now I will get to the ultrasound. Now if I am sterile, I will ask my assistant to get me the ultrasound sleeve. If you don't mind, if you can get me the sleeve there and open it for me without touching the inside. Okay, now I will take the inside if I'm sterile, wearing my old sterility, and I will open that sleeve. Then I'll ask her to turn the ultrasound on. This probably is a good size gel. One option, you can put this gel on the patient sterile skin. Then what I will do, I will get my sleeve. Here is my sleeve. I will open it. Okay. Then I will need to get some gel inside. If you can hand me some of that gel. Okay. And put it inside here without touching me or touching the thing. Just a little bit of gel. More, 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 more. So now we are getting sterile, non-sterile gel inside the sleeve. Then what I will do, you can put the probe here inside the sleeve without touching. Now I will get the probe and I will take that out. Then I will spread my sleeve on the cord of the probe. Now my probe is sterile. Then I will get my 2 rubber bands. I will be sure that some of the gel is in front of the probe. Then I will put 1 rubber band very close here with some gel inside, and the other rubber band more distal to keep the sleeve. Now my probe is sterile, and I will put it also on the tray. Now my syringe with the needle. Okay, this is my syringe with the needle. Let me, before I go there, show you a small trick for the wire. Here is my wire, and here is my syringe. When I get blood, I will be probably that length. If you look at that, I will put my nozzle here inside the back of the syringe. So here's my wire inside, and I can move. You see this black line? This means it's 10 centimeters. I will push. This is away. Sometimes your thumb is slippery from the gel. What can you do? What you can do, release your thumb, pull back the plastic part, the wire will not come back. Half an inch, fix the wire, push it in. Remove your thumb, pull back, fix your thumb, push it in. Again, you see this is my 2 marks, this means 20 centimeters. Look, when I have my 20 centimeters inside the, just close to the syringe, my wire started to come out of the needle. So at 20 centimeters with this long needle, your wire just barely entered through the vein. So if you see, if I go to 30 centimeters with this three marks, This tells me at 30 centimeters. I have at least 10 centimeters of the wire inside the vein of the patient. I usually don't go deeper than that because now I know I'm deep enough inside the vein, but not too deep to reach the right ventricle to cause VTAC. The second thing, when I take my plastic part out and take my syringe out, I will have enough length of the wire to feed the triple lumen on it without needing to push the wire back. So this is the good thing. Wire always should be in your hand, and never try to pull the wire through the sharp edge of the needle. So if I want to take this wire out, I have to take everything out if I have problem feeding the wire. Now here, to get it back, I will pull it from the needle here, and I will feed it back to the syringe, to the cover. Okay? So this is just to show you how deep you need to go with your wire. If you reach 30 centimeter mark, this will be enough depth for your wire inside the patient. Not very deep to cause VTAC, and not very deep so you don't have enough length of the wire to feed the triple lumen on. Okay, let's start with the first step. I'll get back to my probe. This is my needle. My needle is well fixed. Bevel up. I will get my probe. Here is my knob, more medial. I see my artery, I see my vein. Now I will concentrate on the screen. I'll keep my vein in the middle of the screen. My needle with bevel up, I'm holding in a way that I can suction, and I will go 30 to 45 degrees. Don't go perpendicular to the skin, because this will get you to the artery. You need to go 45 degrees, 30 to 45 degrees. Your needle should be touching the probe of the ultrasound. Don't leave a big distance between it, because you will not see your needle on the screen unless your needle is below the probe. Here's my wire. I would like the needle to be coming from the medial end to the lateral end. This is the medial with the green dot. This is the lateral. Here you see more medial, posterior is the artery. So I want to avoid the artery, so my needle, I like it to be coming. One option before I go with the needle, with your finger. If you keep the vein in the middle, and with your finger compress, you see I'm compressing exactly on the vein. This will be a good spot. Another thing, you can use your dilator to compress. Keep the vein in the middle. Then in the spot you will go with the needle. You see, I'm just going inside the middle of the vein. Now I'll get back to my syringe, bevel up, and 30 to 45 degrees, touching the patient skin exactly at the probe site. Now I will go with my needle. You see my needle is coming as this white dot. It's coming from medial to lateral towards the ipsilateral nipple, and I'll start suctioning when I'm going in. And now I'm getting blood. I'll put the probe aside. This is the most important step because you may lose your vein at this point. I will put my hand on the patient's chest and fix my needle and suction again. I'm still getting fluid here, which is blood. Now I am in a good position inside the vein. What I will do, I will get my wire. I'll hold it like a gun, like what we talked about. I'll put my wire nozzle inside the back of the needle. I will start feeding. Here's 10. I'm feeding. Here's that I'm 20. So at 20, now I just went out of the syringe. Very easy going, no pressure. Another way, you can lower your syringe so you'll be more flat with your needle. Now here's my 30 centimeter water. So once I get my 30 centimeter water inside the syringe, I'll take my plastic part out. Now, once the wire is inside the patient, should never leave your hand. Wire should be in your hand all the time. Wire is like a bike. You cannot put two things on it, just one rider. Now we have the syringe with the needle. I'll hold the wire and I will pull the syringe with the needle. Then I will hold the syringe and hold the wire from the other side. Now my needle and the syringe are out. I'll put it here in this one in case I need it back. Then I will have my wire here. Wire here is deep enough to be inside the vein and long enough outside the skin to put the triple lumen. If you will do incision, you can do the incision now, but if you do the incision, be sure the sharp part of the scalpel is away from the wire. This wire is a wire around the wire. So there are two wires, one central wire, another wire around it. If you cut it with the sharp part of the scalpel, in this condition you may get the outside wire, unscroll inside the patient, you get what we call wire embolism. Also, if you leave the wire from your hand, you may get wire embolism. So I usually don't cut. Another way, if you want to do incision, small incision, you can do that before you take the syringe and the needle out, because your wire now is protected by the needle. So you can do the incision at this time. Will not do the incision for the mannequin, and I usually don't do that. After you do that, you need to dilate. Dilator, you feed your dilator. Dilator is longer than the depth that you need to go. So here's I'm feeding my wire into the dilator. It's important when you dilate, don't hold your wire very high, because if you hold the wire this high, the dilator will kink the wire at the skin area. So your wire should be flat so you can place your dilator. I hold the dilator close to the skin part, and when I go inside the skin, I will keep the wire in my hand and I will scroll to dilate and push in until I feel the resistance went away. You don't have to go full length. You are dilating the skin. You are not dilating the vein. Once I feel the resistance went away, probably about half of the dilator, you'll feel there is no resistance, then you take your dilator out. In this mannequin, so we don't damage the tubing, we will go like half a centimeter to dilate to get the feeling how we dilate. Then I will put my probe on the other side. Now I will get my wire. Again, my wire is in my hand. I have enough length of the wire to get it out of the brown port without need to push it again inside. Now I'm feeding the wire, always the wire in my hand. When I reach with the triple lumen close to the skin, look here, I got the wire out of the brown open hole, okay? Now I'll hold the wire from the other side. Also keep your wire down so you don't. Then I will start holding the triple lumen close to the skin, half an inch to 1 inch, and feed slowly, 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 slowly till the length. Let's go to 15 centimeter. Assume we measured 15 centimeter. Now I will get my wire. Now I need to get my wire out. So what I will do, I will get my other cap and I will get that wire out, pull the wire out, so I don't get too much bleeding. I can close and then put my cap on. Now all my 3 lumens are capped. Let's see here. I am in, but I want to be sure I am in. So what I will do, I will get a syringe with some saline in it, and I will put it inside, and then will suction first, get blood, then inject it back. Be sure the 3 lumens are open. Okay, good. Now I want to suture. Look here. This probably was a little bit too long tubing for this patient, too long triple lumen for this patient. I will not suture here in the face, right? So you don't want to get a scar, especially if your patient is a lady, even if a man. So you don't want to leave a scar on the face from the sutures. And you don't want to curve this way to suture it. So I don't recommend that you do this curving, because this curving will make this area will be loose, can go in and out. When it goes out, it gets infection. When it goes in, it will get the infection inside the system. You get central line related infection. So you should never do that. That's why if your patient needs less than 15 centimeter, maybe it's better to use 15 centimeter catheter. What can we do to solve this problem? One thing, we have these 2 pieces. The white is softer, so I will put this white thing just close to the skin. Then I will put the blue part on top of it. Then I will suture it. Okay, now you are suturing very close to the skin. Make sense? Some places don't want to suture. There is very weak data that suturing may increase the chance for infection, which is a small study that was done in PIC line, 15 patients compared to 15 patients, and the stat log reduced the infection compared to the patient. This is how the stat looks like. Now, not everybody is very enthusiastic, but stat lock is a thing that can stay for a week. Then we need to change it after a week. So it has here some adhesions. So this, how you do the stat lock. So this is towards the head. These are towards the head of the patient. What you can do, you can put this thing here inside. and you can lock these things on top of them. Close that, and then close the other one, and you stick it to the patient. Okay? To remove it, you need alcohol to remove it because it sticks. Also, it has another piece. Usually, you shouldn't do that on the patient face, but another piece that also can hold the other 3 lumens. So this is another piece. Also, you can stick it, and you can put the 3 lumens inside it. So it has 3 grooves for the 3 lumens. Okay? You can put those, and this is how the stat lock looks like. Okay, you do either the suture or the stat lock. If you would suture, then you suture it in a way that you can easily remove the sutures. Great. One option also, once we place the line, even when we place the wire, you can look at your ultrasound and be sure your vein is, your wire, you see my triple lumen? So this white dot inside the vein, my triple lumen is inside the vein. I can do longitudinal position. And look here, my lumen is, my triple lumen is inside the vein. Make sense? So this is how you do it. Now you put the dressing on top. Dressing should be transparent so you can see your area. If you see any erythema or anything like that, you look for any line infection. And at the end of the procedure, you need to get rid of your sharps. And after you get rid of your sharps, you document your procedure at the end, documenting that you got a consent or not, and what medications you used, document the steps you did, and if there is any complications happened after the procedure. And thank you very much. Now we'll get to the removal step. Again, flat or Trendelenburg. We talked about these holes. So you put the patient flat. If your bed can be a Trendelenburg, you can put it in Trendelenburg. Cut the sutures, ask the patient to hum, and once the patient hums, you remove quickly because this can be something that can get you air embolism. As we said, if your proximal hole is outside the skin and your distal hole is inside the vein, which is larger distance than the distance that we measured, 1.4 centimeter. This is about 3 centimeters. Patient takes a breath, he can get the air from outside the skin and get air embolism. If you get air embolism or you suspect getting air embolism, you put the patient in Trendelenburg on his left side to keep the air and the right ventricle away from the right ventricular outflow tract. Again, this is the central line procedure on our mannequin, and we will start practicing after that. Thank you very much.